I would now like to welcome Dr. Patrice Lindsay, Director of System Change in the Stroke Program here at Heart and Stroke.
Good afternoon, everybody, and thank you very much for joining our webinar today. We appreciate everybody's interest, knowing that this is a very busy time of year for everyone. Today, we have brought you a stellar cast of presenters to talk to you about a very important topic and one that's a priority area for the Heart and Stroke Foundation. We're today going to talk about the area of rehabilitation, and very specifically, unique issues and considerations for women who participate or have trouble even accessing rehabilitation. We're going to look at it across all the conditions that we're interested in, including heart conditions, stroke, and vascular cognitive impairment. To get us started today, our four speakers are going to include Kelly Saylor, who's a teacher and also a person who's experienced our conditions, and she's going to talk to you a bit about her personal experience and some of the things she observed and learned that will very much help us as health professionals in caring for women in the rehab setting. She'll be followed by Dr. Anita Mountain, who's a physiatrist in Halifax at the QE2 in the rehab center. And she'll be talking about the unique aspects of stroke rehabilitation in women. Jennifer Price, who's at the Women's College Hospital in Toronto, will talk to us about cardiac rehabilitation in women. And then Jodi Edwards, who's at the Ottawa Heart Institute and a research scientist, will talk to us about vascular cognitive impairment, which is a much newer area and an emerging area where we still have a lot of gaps in our knowledge. And she's going to let us know where we are now and where the future of research and care needs to go in that domain. So the objectives of our panel today are to engage in meaningful discussions. And to that end, we really encourage you to use the chat function and submit questions throughout the presentation. And then we will be sure to do our best to read as many questions and have our panel answer them during. And any that we don't get to, we'll try to get answers to you offline. So it's really a discussion. We'll hear from our experts, and then we want to hear from you on your issues, challenges, questions you have. We want to recognize that there are gaps and there are inequities and differences, sex and gender differences in access to rehab, which therapies work better for one gender and sex or the other, and also to address how we maybe approach things differently for different sex and gender. We're also going to look at some of the interventions and the science and knowledge behind those from a sex and gender perspective, and really want to apply all of this to your daily practice so that after the webinar, you learn some things that you can actually apply to practice directly. And without further ado, we will turn it over now to Kelly.
Hi, thank you for having me today as a panelist. I just wanted to get started by telling you a little about myself. I'm a 42-year-old married mom and educator. I live in Niagara. In my mid-20s, I started suffering chest pain and jaw and neck pain that was repeatedly misdiagnosed as stomach problems, even though all my tests would come up that I had nothing wrong with me. Eventually, I stopped seeking treatment for that pain. And in June 2011, after the birth of my youngest child, I was misdiagnosed with a gallbladder attack after presenting with much more severe chest and back and neck pain. In November 2012, I suffered the first of 2 strokes, resulting in impairments like memory loss, aphasia, left side numbness and weakness, balance, and vision problems. I was misdiagnosed with anxiety for the first 3 months following that stroke, until my husband came with me to the doctor and insisted I see a neurologist, at which time I ended up having an MRI and they diagnosed the stroke. And I was given what was called the $1 million workup and was told that my stroke was just a fluke. For the next 6 years, I suffered severe chest, back, neck, and jaw pain that would last for hours on end. I was repeatedly misdiagnosed with esophageal spasms and reflux, and despite my objections, they would not change their mind about that. I stopped seeking medical help and would just face the floor in pain until May 2017, when I suffered the second stroke in the hallway of my school. My coworkers called an ambulance, and I was sent home from the hospital after being told that I probably just fainted, even though my symptoms did not agree with that diagnosis. To appease my husband, I was sent to a diagnostic clinic, and then after that, we were sent to the stroke clinic. About a week later, I was diagnosed with a blood clot in my aorta, just outside of my aortic valve. The diagnosis of aortic dissection followed that. So I was ambulanced to Hamilton and had emergency open heart surgery and had an ascending aortic replacement. So after my first stroke, I was offered no rehabilitation or assistance of any kind. By the time I was properly diagnosed, I appeared to everyone to be in such good health. I think they just thought I was fine and I didn't require anything. I did, however, continue to have impairments that were very obvious to me and not so much to other people. So impairments like aphasia, numbness and weakness in my lips, my tongue, my extremities, balance and vision difficulties, and a lot of difficulties with memory and memory loss and short-term memory. I was responsible at that time for caring for 2 very young children in my home, and I worked full-time, and I was also in university. I had to drop out of the course I was taking as I couldn't even recollect what I had learned in the last couple of months. I would have liked to have those impairments addressed at some point. I would have loved to have some kind of therapy that would address my memory, even some memory games of some kind. I was looking online trying to find things for myself instead. Ultimately, I just feel like no one thought that the impairments were that serious, and so they didn't feel that I needed anything to help with them. Following the second stroke and the subsequent open heart surgery, I was offered only cardiac rehab. Through this cardiac rehab, I was able to access some cognitive therapy with a counselor. Unfortunately, I find that cardiac rehab, because it takes place during the day twice a week, it limits the people who are able to come, because for those of us who have to go back to work, we can't attend. My doctor was originally going to send me back to work, and I after discussing it with him, he decided that I should attend the rest of the cardiac rehab. But for other people, they won't be able to attend. Most of the individuals there were older adults who were retired, and most of them were men. I was by far the youngest person and the only person who was going back to work full time and who was caring for children. Unfortunately, I did have to stop attending my cognitive therapy as well, because it was also only offered during the day and it had very short, limited availability. This was something I feel could have really helped me upon my return to work, as I suffered a great deal of overwhelming feelings upon returning to work. After telling the cardiologist about that, he referred me to a psychiatrist who diagnosed me with PTSD, but unfortunately he only gave me a prescription and didn't really help as far as that was concerned. One of the major problems I found upon returning to work was that my doctor didn't understand the job that was required of me at my job. He sent me back with a lot of restrictions, and I specifically work with children with disabilities. So my job can get, sometimes the children can get violent and upset. So I cannot be hit. And he was upset about the fact that he had to write a note that said I couldn't be physically assaulted in my place of work. I find that my job is a job that a lot of women do, and unfortunately the doctor didn't understand my job and what was required of me. My biggest and most important complaint I had with my recovery and my rehabilitation was the fact that being a mother is highly underrated by most of healthcare professionals. They were in a big hurry to push me back to work, but nobody understood that my kids were always going to come first, even if I had to go back to work. Being a mother is not something I'm going to just stop doing. And when they would tell me I was doing too much, I would say, well, I have to take care of my kids. I can't just stop taking care of them. My husband was very helpful with housework and things like that, but still spending time with the children and attending their extracurricular activities was important for me. Another important point to make is that my husband couldn't understand why my healthcare team required him to be there to vouch for me, to make what I had to say believable. That was a big problem for him, and it is for me. It continues actually to this day, that he has to be there to say, yes, this is what's happening, in order for someone to believe me. In conclusion, I just want to say that I think we need to have, first and foremost, better and more timely proper diagnosis. I can't stress this enough. Without this, there's no hope for rehabilitation or recovery, because without diagnosis, we can't get to the rehabilitation part. I now have a rule where if a doctor says probably just to me, I say, let's do a test, because I was letting too much go myself. I didn't want to hear that I was sick. I wanted to be healthy. I wanted to keep going, take care of my family, do my job. And I ignored a lot of my own symptoms as well. I feel like a lot of women do that. We don't want to appear weak or incapable or sick, and we want to keep going, so we just push through, and we don't allow ourselves that time to heal, the time that we need to heal. I also think there needs to be a better bridge between rehabilitation professionals and doctors, because I was not referred to the rehabilitation that I could have been referred to otherwise. I had no idea what was out there or available to me. I also think that rehabilitation needs to be offered during different times of the day. If it's only open during the day, people are not going to be able to attend. We need childcare options for women who have children still. And I feel like we need to understand that women, that most of all, that women are not going to just drop their children and take care of themselves. We never do that. We always take care of our children first. So that was something I really wanted to stress today, because I feel like I was not understood in that manner, and I'm still not understood in that manner. I think that's all I have to say for now. If there's maybe some questions that come up, I could answer. But
Great. Thank you so much, Kelly, for sharing with us. I think you've made some really important, excellent points that will hopefully be addressed by our other speakers throughout the rest of the session. But I really appreciate, and we're so honored that you're here with us, and so proud of your recovery and what you've done. So thank you for being part of this and for getting us started. So we'll now move on to our next speaker, Dr. Anita Mountain. And Anita will speak to us about stroke rehabilitation.
Thank you, Patty, for that introduction. And I'd also like to thank Kelly for sharing your experiences with us. It really does help to put the rest of the presentation in context and highlights important areas to be considered as we continue to advocate for more research and system changes in this area. So for the next 10 minutes, I'm going to discuss some of the important concepts relating to stroke rehabilitation considerations for women. Oh, I'm just trying to advance the slides here. No. Patty, I'm having advancing the slides.
Go ahead, Anita, try again.
Okay, let's try here. No. Oh, there we go. Oops, okay, there we go. I think we're good here now. Okay, sorry about that. Okay, so I'm hoping this presentation will help you to be able to identify some of these important objectives, which include identifying differences and factors contributing to these differences in functional outcomes for women following stroke, as well as some of the challenges and gaps in this area. Oh, sorry, there we go. So when we look broadly at functional outcomes following strokes, many studies have shown us that women do not achieve the same functional level as men. So this paper was one that was published in 2015 that looked at trends and projections of the prevalence of individuals experiencing stroke in Canada based on the Canadian Community Health Surveys in 2011. They looked at population prevalence as well as estimated absolute number of people living with the effects of stroke in Canada. And what they found was that women had both an increased population prevalence, so as you can see 1.12 versus 1.1% for men, and that there was a total higher absolute number of women living with the effects of stroke than men. And when this was further broken down by age ranges, we can see that the majority of this difference is accounted for by those living over 80. where there is an estimated approximately more than 40% more women than men who are living with the effects of stroke. But as you can see, indicated by the stars, there are other age ranges where women are living with more of the effects of stroke than men. But for the majority of the age ranges, it's actually the opposite. There was also more women living in what they termed home for the aged. This is not surprising after that age of 80, but it holds true even at those ages where there are more men living with the effects of stroke, but more women who are living in care, which are indicated by the stars in the slide. This is most notable in the 75 to 79 range, where there are many more women who are living in care, even though at this age range there are more men living with the effects of stroke. And this is especially significant when we consider one of the most important outcomes for people following stroke is the ability to return and remain in their homes. So what are the factors that contribute to this difference in functional outcomes? Well, many studies have looked at this, and this is a recent article that was published in 2018 that looked at 11 stroke incidence studies from 1993 to 2004. And their analysis showed that while women had worse functional outcomes and greater participation restrictions than men, these differences were actually attenuated when adjusted for age, pre-stroke dependency, and stroke severity. And these same factors have been found in many other studies as well as being one of the most impactful on outcomes. So this next study looked at the effect of many variables on age-adjusted outcomes. And again, we see differences that can indicate poorer pre-stroke function and health status are very important factors in outcomes, as well as marital status, which may indicate the availability of someone to help with ADLs and IADLs following stroke, which may help people remain at home as well as improve function. And the author of both these studies make the point that prevention efforts aimed at maintaining functional status in aging women may be an important target to improve post-stroke outcomes. And pre-existing functional limitations may also impact the effectiveness of post-stroke rehabilitation, so become important in that manner as well. Now, I wanted to show this next study because it looks at the components of function at a different level of granularity and for the population that are admitted to inpatient rehabilitation. So it was a retrospective study of over 125,000 people discharged from inpatient rehabilitation facilities in the US over a 2-year period with a dichotomized outcome. So a FIM greater than or equal to 5, so those who only require supervision or are independent or modified independence with tasks, and those less than FIM less than 5, and so that means they require some degree of physical assistance. And this study showed that women had equal or greater chance of reaching supervision level on all components of the FIM, except upper body dressing, which the authors postulated may be related to the difficulty in donning a bra after stroke, and doing stairs, which is felt to be a task that could be impacted by pre-stroke factors such as premorbid strength. And unlike other studies, while there was a statistical difference in the discharge FIM of men versus women, it was by less than a point. And so this may not be a clinically significant difference, as you know. So it would seem that the women who were admitted to stroke rehab in the study did have similar outcomes as men, although in different components of the FIM, which is interesting. And so there are also differences in the self-reported outcomes by men and women following stroke. This study included all first ever stroke patients between the ages of 18 and 55 in the Swedish National Registry for Stroke. And what they found was that in this study that women reported more difficulty than men in many areas, included memory, concentration, overstimulation, fatigue, and physical function. Women than men also reported that they have received insufficient information about these changes, which may also highlight the need to provide information with different content or method of information delivery and provision for men versus women. And there are also differences when it comes to life satisfaction and quality of life. In the study of life satisfaction in younger individuals following stroke, the only area of dissatisfaction that women were more dissatisfied with was with their vocational and financial situation compared to men. As you can see, there was lots of areas that there were dissatisfaction, including family life, friends, family contact, and other areas. But in terms of differences between men versus women, it was with vocational and financial situation. And so this tells us that we may need to put more emphasis on these areas in our rehab programs and community transitions, or as much emphasis with women as we do with men. And women also demonstrated lower quality of life scores. So in this study at 3 and 12 months in the areas of mobility, daily activities, pain, and anxiety, women were less, showed less satisfaction with their quality of life. And they were also in the study less likely to be married and more likely to live alone. And stroke can also affect women in the role as caregivers. So women are more likely than men to take on a caregiving role, spend more time caring, perform more personal care tasks, and not take advantage of informal support systems. They are also more likely to experience anxiety, depression, and physical symptoms. And for men, their emotional and physical symptoms were more strongly related to their spouse's cognitive and psychological function than their physical abilities compared to women. And we know that the caregiving role can impact a caregiver's participation. And while the study did not show a sex difference in terms of participation restrictions between men and women, we do know that there are more women caregivers than men, so these issues would also differentially affect women. And currently, in terms of the delivery of rehab interventions following stroke, there is no real difference in the content of the rehabilitation techniques that are used based on sex. But in this study that included randomized controlled trials on stroke rehab, they were looking more at the age, but what it also found that in addition to there being a age bias in that people who were older than 65 were not as represented in the studies, there was also found to be a sex bias with almost a 60-40 split, men versus women. So have our studies been on therapeutic techniques included an adequate number of women or been designed to even detect a difference if a difference does in fact exist? And so while there have been many differences reported between men and women following stroke, we still need to have a better understanding of why those differences exist. So knowing the importance of pre-stroke functional status on the outcome of women after stroke, particularly older women, do we need to look at improving the function and status of our at-risk population to help them maintain their abilities as they age? Do we need to look at making changes in the systems and models of delivery of rehabilitation programs, looking at models would best serve the unique needs of women, both younger and older? And certainly Kelly's experience highlights some of those difficulties, particularly the difficulty being able to make it to inpatient or outpatient programs with competing responsibilities such as parenting and work. What about who's accepted for inpatient rehab programs? Do some inpatient rehab programs have an inherent bias against women who make up a larger number of the older population and those with more severe strokes? Would younger women who have many diverse roles and responsibilities be more likely to participate in equally intense outpatient versus inpatient programs and programs delivered at different times? And do we need more home-based programs or more programs supported by technology to allow women in rural areas or those with difficulty with transportation access rehabilitations? And do we have enough information or programs that look at the unique stresses and needs of women caregivers? It's also really, really important to understand if there are differences in the pattern of neurorecovery and responses to specific therapeutic techniques that are unique between men and women, so we can tailor our therapeutic interventions to maximize the window of recovery. So now that it's clear that differences exist, our challenge now is to research them more fully and make sure that those issues of sex and gender are explicitly inherent in future trial decisions to help us answer those questions and maximize our rehabilitation programs. Thank you.
Thank you very much, Anita. That was an excellent overview for stroke rehab in women. We really appreciate that. We're now going to turn it over to our next speaker, who's Jennifer Price. Jennifer is the Chief Nursing and Professional Practice Executive at Women's College, and Jennifer's going to talk to us about cardiac rehab. So Jennifer, over to you, and you've got control.
I have control. Thank you, Patty. Thanks for the invitation to speak today. I want to talk to you a little bit about cardiac rehab and some special unique characteristics for women. Sorry, I don't seem to be moving the slides forward. I'm going to touch on depression, anxiety, religious and cultural differences, other responsibilities such as caregiver burden, frailty, and some issues around pregnancy. And sorry, can you move my slides forward? They're not moving for me.
Try again now, Jennifer.
Yeah.
Okay, I'll take care of it.
Thank you. So just to set the stage, I know everybody knows this, cardiac rehab is cost effective and is a class 1 recommendation for the majority of patients who have cardiovascular disease. We know that it increases exercise capacity, the cardiovascular risk profile, social functioning, psychological well-being, and mortality rates. And despite this, cardiac utilization remains low, especially for women. Women are less likely to be referred, they're less likely to attend, and they're less likely to complete their cardiac rehab. If you could move forward, please. One of the initial issues is actually getting a referral to cardiac rehab. And this is for both men and women. Getting a referral can be an issue, but it's even more so for women. We know that things like automatic referral, coaching interventions post-discharge from hospital, and strong support from the healthcare professional actually all enhance women's ability to get a referral. And early referral is especially important to women. They are more likely to attend rehab if they have an early referral. There are some barriers to intake assessment in women. Even if they do receive that referral, we know that women are more likely to have transportation issues, competing responsibilities, and Kelly spoke quite eloquently to the caregiving piece. They're more likely to have some non-cardiac health concerns and non-health concerns, and really a lack of self-efficacy for exercise. So women are often unsure about what they should be doing for exercise and unsure of their ability to exercise. We looked at some of our data at the Women's Cardiovascular Health Initiative and found that about 25% of our women who were referred did not attend. And really it was around distance and transportation, so including travel costs, parking, gas prices. We heard women talk about only having one car in the family and not wanting to take it away from the rest of the family. They also talked about their family and work responsibilities, fatigue and anxiety. When we look at women in cardiac rehab, we do find that, especially in the younger women population, which is less than 65, that young women are more likely than young men to experience depression, anxiety, have higher stress at home, and have a low household income. And we do know that cardiac rehab can address anxiety, depression, and increased quality of life. So it's making sure that we're paying attention to these depression, anxiety, and stressors in our women so that we're actually addressing that within the rehab program. There are also gender differences, even within religious and cultural groups. So cultural differences, we see differences in attitudes and experiences towards physical activity. We know that many Muslim women cannot exercise in a mixed cardiac rehab setting. So can we offer women-only classes for them? We actually ran a program in a mosque where we ran the program in the sisters' room so that it was just the South Asian Muslim women. But we also need to look at the socioeconomic barriers to rehab. Even in Canada, where rehab is free, getting to rehab and paying for transportation and other things can be a big barrier. Kelly talked about being a mother, and that's something that you can't stop ever caring for your children. We do know that more women are likely to be caregivers and are disproportionately likely to spend more time than men providing caregiver support and tasks. And it's children, but it's also women are often caught in that spot where they have their own children, but they also have their own parents that they're caring for as well. So it can be a quite difficult time. We looked at our own population and we looked at what is a caregiver, just trying to understand what kind of things that they were doing and to see how patients were feeling about them. And we found that 50% of care recipients were parents with complex and demanding caregiving needs. That in our population, 60% of our women averaged about 22 hours per week of caregiving time, and most of that caregiving was when not co-located with the care recipient. So these were women who were driving to parents' houses, brothers' houses, sisters' houses to provide ongoing care. 58% had a high degree of distress, and 10% said they were overwhelmed. Things that they asked for was more patient support. We actually did this study to look at caregiver burden because women were asking about it. They talked about wanting internet resources that could be provided to them. We actually started running workshops on principles of safe care, managing sleep issues, cognitive behavioral therapy, and mindfulness for these women. Even some practical tips. One of our patients had to get her brother to stay with her parents so she could physically come to cardiac rehab. And she said to our physiotherapist, what am I going to do now that my rehab's over? I've got to go back. And Debbie quickly says, well, just don't tell him you're done. Just keep taking that 2 hours out of your day twice a week. Let him care for your parents and you care for yourself. Anita mentioned the functional capacity and how important that is. And we do see that women are more likely to be frail, which is a clinical geriatric syndrome, and that they have an increased risk of frailty versus men, and that is linked to adverse outcomes from following cardiovascular surgeries. There's not much evidence out there around frailty in cardiac rehab. People are starting to look at frailty in general. We actually looked at our study using a retrospective frailty index and found that about 50% of the subjects in our rehab were mild or moderate frail. The most frail had the lowest functional capacity, but all our patients did improve. So even the most frail had improved METs at discharge. And this is particularly important when we realize that we realize a 13% decrease in mortality with a 1 MET increase in functional capacity, which we can attain in cardiac rehab. So we would suggest that we might want to start including frailty as a routine assessment in our, particularly in our older patients. There's some good Canadian tools to look at, especially the clinical frailty scale, which is a very easy tool to use. And there's been a lot of research done on that because it does beg the question that we might need some other supports in cardiac rehab, such as geriatricians or neurologists. And it really has forced us to know our community and know our partners so that we are referring to regional geriatric programs and community health centers that do have geriatricians to help us out. We are seeing more and more younger women. This slide is from a trial that we're doing with our women who've been identified as having gestational diabetes. But I would say, to Kelly's point, we have quite a cohort of women between the age of about 40 and 60. They do have some unique health concerns that we need to be aware of. Especially in our gestational diabetes population, we think about issues around pelvic health, incontinence, who assesses that. We routinely screen for that in all our women because our older women complain about it, and then our postpartum women complain about it. And a lot of the myths around breastfeeding and exercise we need to overcome. So as a healthcare professional, we really look at the idea of health promotion. What's the role of physical activity in a healthy lifestyle, and really getting to them pre-event if we can, so that we can improve their functional capacity. It's really important to build on your therapeutic relationships with your clients, know their medical history and sex and gender specific risk factors. Look at appreciating life stages of women because things are different, postpartum, menopause, or the frail elderly. Really pay attention to those competing roles and role resumptions. Help with social support systems and be culturally sensitive. In summary, cardiovascular disease continues to be a leading cause of death. We know that cardiac rehab works for women. There's gender-related characteristics that influence the risk of CVD and also affect attendance at cardiac rehab. So let's start to look at some different programs. Kelly talked about flexible hours. We use alternative delivery models. We use home programs, telemedicine to see what would be more suited to women and just try to make the program more accessible. And with that, I will thank you for your attention. And I'm going to turn it over to Jodi Edwards, who's going to talk about cognitive rehabilitation considerations for women.
Thank you.
You should be good to go, Jodi.
Okay, let's see if I can advance. So it's also, oh, there we go. Are you doing that, Patty, or am I?
I think you are, but I'll try to give it to you again. Try now.
Okay. Well, thank you very much for the invitation to speak about this topic. My literature search really focused in on specifically cognitive impairment and dementia and considerations for women. So we know from about 6-year-old data now from the Public Health Agency of Canada that dementia and cognitive impairment prevalence and incidence is on the rise. This is affecting a little over 400,000 Canadians aged 65 years and older living with diagnosis of dementia, and really critically about 2/3 of those are women. So we know that this is disproportionately affecting women. And at every time point here in this graph back dated to 2014, the incidence and prevalence of dementia for women was in excess of that of men. So this is certainly something that's higher prevalence among women. And then in follow-up work to this study, there was a survey data that demonstrated that cognitive impairment without a diagnosis of dementia is even more prevalent, and that vascular cognitive dementia really comprises about 10% of this. So this is something that is an increasing health burden and one that's specifically impacting Canadian women. There was a consensus guideline document recently published in last year that really gave some definition around what is vascular cognitive impairment. And it's that which clinically manifests as a significant deficit in at least one cognitive domain with sufficient severity to impact activities of daily living. And then another consideration is for either mild or major VCI is imaging evidence for cerebrovascular disease. And these can manifest as any of these indicated here in the diagram as white matter disease, microinfarcts, or large infarcts are also brain atrophy. So armed with this definition of what cognitive impairment is, this document also really outlined the different pathways by which individuals can become cognitively impaired. So certainly after an acute ischemic event, people can manifest with post-stroke dementia, but there's also some subclinical manifestations of this disease, either subcortical ischemic vascular dementia, multi-infarct dementia, that's more cortical level, or mixed disease that co-occurring with some of the more Alzheimer's dementias proper. And so given all of the different ways within which people can become cognitively impaired, Jack actually convened a scientific expert panel to really look at some of the modifying factors of these different pathways to cognitive decline. And specific to sex as a non-modifiable risk factor, this panel really demonstrated that, and this was based on quite limited evidence, but they showed no associations between sex and post-stroke dementia, but really focused in on vascular dementia as an area. My little diagram is delayed there. Vascular dementia as an area where there's some conflicting or really insufficient evidence around whether or not there's sex modification. So I'm going to focus in on this area of vascular cognitive impairment and focus on what we know and what's kind of shown in the literature for intervention of this to either prevent or slow the progression of this decline. So there's sort of 4 specific interventions that have been looked at in depth in the literature. Pharmacological interventions, of course, exercise as a modifier, cognitive training, and multi-domain lifestyle. And again, I want to focus specifically on the reported literature with respect to sex-specific indications for women. So the first kind of foray into looking at intervening for vascular cognitive decline was really the application of some known indications for Alzheimer's disease, such as cholinesterase inhibitors, into the VCI population. And there were a kind of a cluster of double-blind, placebo-controlled RCTs on this in the early 2000s. Given the effects of sort of a really modest benefit for cognition and quite inconsistent across studies for global and daily functioning, none of these therapies have actually met regulatory approval for VCI as an indication for VCI. And critically to women with the burden of this disease, none of these trials also reported sex-specific treatment analysis. So I think that although there was shown modest benefit for cognition overall, we also have really no sense of whether or not there was a differential benefit for women versus men from these trials. Of course, there's multiple well-known, high-profile vascular risk modification trials that bear upon this as well. Specifically, I focused in on the antihypertensive blood pressure lowering trials, PROGRESS and PROFESS and SCOPE and HIVET, and there's also a number of statin therapy trials that have looked at modifications for cognition. For the antihypertensives, the overall from these stroke VCI recommendations in 2011, there was a reported level evidence of B for the lowering of blood pressure in the mid-age to reduce the risk of vascular cognitive impairment. But really, in the primary reporting of these analyses across trials, only HIVET COG actually even reported a modification analysis, and they showed that there was no modification by sex. So it's a bit inconclusive as to whether antihypertensive medication shows any kind of preferential benefit maybe for women, or even a benefit at all across regardless of sex. And then for statin therapies, again, the Sparkle and Prosper trials, they really showed no evidence for the prevention or slow progression of cognitive decline. And again, there was limited sex-specific data. So I think that in terms of the trial literature, there's really, there are some unknowns and there is insufficient evidence, as the expert panel did note. But when we turn to the observational data, there's actually some interesting and important effects that have been shown, showing an increase in risk associated with mid-adulthood hypertension among women. Specifically in this study looking at prospective data from the ERIC study, mid-adulthood hypertension was associated with an increased dementia risk of 65% for women versus men. And then it predicted a 73% higher risk within the women, in those women with hypertension versus normotensive women. So I think that this really indicates that there is an increased risk associated with hypertension, and that this is not played out in the trial literature with respect to modification of this for antihypertensive therapy, but more really it merits more exploration. And also in a Canadian study looking at health measures survey data, it showed that Canadian women, despite being on treatment, were 2.5 times more likely to have uncontrolled hypertension. So we really have this kind of increased risk associated with hypertension, and then despite treatment, having it uncontrolled. So these observational data do point to the need, I think, potentially to look more at hypertension and its modification for vascular decline in women. The literature that has really shown sort of the most robust evidence in terms of interventions for cognitive impairment is the exercise literature. There have been a number of smaller trials in this area, and this meta-analysis I report here shows is an analysis of 39 of those trials, reporting on a little over 5,200 individuals. Now, these trials range from either 0% inclusion of women all the way up to 100%, but the mean was actually around 70% participation of women. So there's really an adequate representation and enrollment for women in these trials. And the trials examined several intervention types: aerobic training, resistance training, and multimodal training. And overall, sort of regardless of sex, there was shown to be benefit for cognitive function, specifically visual spatial function. Aerobic training was shown to have more benefit for global cognition than resistance training, and multimodal training showed benefit for global episodic memory and word fluency. But if you look at this, this plot, it does show these three circles indicate that among women, all three approaches were associated with larger effects, specifically for executive function. So there seems to be a real domain-specific benefit of exercise training for women with respect to executive function. Now, of course, there's always some contradictory evidence. The first I want to highlight is a women-only single-blind parallel RCT that was conducted that was consistent with the prior studies and showed a benefit in neurocognitive function. But it was interesting to me because it also showed increased levels of plasma BDNF associated with exercise in this women-only trial. And this was from a 16-week multimodal exercise program in elderly women aged 65 to 75 years. So there's quite a bit of support both for cognitive function and also some biospecimen data showing increased with exercise interventions. But in an MR sub-study of the Canadian PROMOTE RCT that really wanted to quantify if there were sex differences in white matter hyperintensity burden, which, as you remember, was one of those MRI indicators of cerebrovascular disease and cognitive decline. In this trial, they looked at aerobic interventions and showed that it was actually the effects of the aerobic training on the progression of this disease did vary by sex significantly, but that the males actually demonstrated less progression. So they showed that aerobic training may actually curtail or slow the progression of the white matter disease in males, but not in females. So I think that this, merits more investigation around the potential mechanisms of this disease and how exercise is playing a role in modifying that. And there's been also a more recent trial in JAMA of a 24-month physical activity intervention that actually was a negative trial. It showed no overall effect of the intervention on global or domain-specific cognition, and no sex-specific differences. So I think that there's a lot of good evidence around exercise as an efficacious intervention potentially for women, but there's still some contradictory evidence out there, and it's an area that certainly requires more exploration. There's been a number of efforts to look at cognitive training paradigms, and I think that this is quite interesting with respect to what Jennifer just spoke about, with trying to engage people more in their homes, in community, with different types of paradigms or interventions that can be more flexible to people's schedules. So there hasn't been a lot of RCT data in this regard. There was a number of studies that have looked at using a computerized cognitive training paradigm, and this is a meta-analysis I present here of 17 studies with a little over 600 participants that showed kind of a small to moderate benefit for global and domain-specific function, but again, there was no sex-specific data reported. But in a recent, just reported last year, BrainMem RCT in this domain, there was 24 sessions of personalized cognitive training with neurofeedback, and there was a significant sex moderation effect, but it showed better performance for men than women. So the authors of this trial actually indicated that that cognitive training may be more efficacious for men than women. So we may need to look at alternative paradigms for women. And then finally, there's been some efforts to look at multi-domain lifestyle interventions. So there was this finger trial reported in 2015 in The Lancet. That was a 24-month multi-center RCT that looked at a broad multi-domain intervention that included nutrition, training, exercise, cognitive training, and vascular risk factor reduction. And there were overall significant benefits for cognition, but it's very tiny. But if you can see in this this force plot here that there was no sex modification with pretty much identical point estimates and overlapping confidence intervals. So it appeared to be an overall benefit for everyone, can benefit women as well, but it wasn't preferential or for men, or there was no difference between them. So I think some of the key considerations in terms of trying to intervene to prevent or progression of cognitive decline is just to recognize that cognitive impairment and dementia are highly prevalent, and the incidence is higher among women. There's relatively few clinical trials of the AD and vascular risk reduction therapies that report sex-specific effects. So again, more trial data is needed, and hypertension is one of the areas that potentially, given the observational evidence, of potentially important focus for women. Exercise shows the strongest evidence of benefit for women, but computerized cognitive training may be less efficacious. We may have sort of a sex-specific choice of paradigms, and just much more research is really required in this area to determine what the best strategy is to optimize rehab. Thank you.
Excellent. Thank you very much, Jodi and Jennifer, Anita, and Kelly. That was a fabulous presentation by all of you. We really appreciate it. We have received several questions, so I'm going to direct those to each of you as appropriate. So the first one is, and I'm actually going to ask each of you to speak to it briefly. Somebody wrote in that we really need to take a more holistic approach to women in rehab. And so from each of your vantage points, how do you see communication with your colleagues on the acute side and the prevention side working with you in the rehab side? And what are some quick wins that other people can try to implement in their practice? So why don't we start with Anita and then on to Jennifer and Jodi. And this is an area that Kelly mentioned as well. So Anita?
Yeah, thank you for that question. It's a really interesting one. I think some of the things that we look at is we have to be able to identify what area we're talking about. I mean, certainly there are so many different things that come into factor when we think about rehabilitation. There's the personal factors, the environmental factors, the contextual factors, how a person's roles and responsibilities impact themselves, and sort of what that means for women versus men versus families versus different roles and responsibilities in different times in the lifespan. So I think there's lots of things that we still need to learn about all those areas, and then there's still the very specific therapeutic techniques and for different types of strokes, for different types of interventions. How can we tailor that to a person, whether they're male or female? In terms of working with other healthcare providers, I think that we, in this age of sort of personalized medicine, we really have to start thinking about all these factors more specifically. And so, we often try to fit people into programs rather than fit programs around people. I think we need to start looking at the unique needs of women at their different life, throughout their lifespan in terms of how we can better fit our programs to the people that we serve.
Great. Jennifer, do you want to comment as well?
Sure. I would say we try to do quite a lot of work with our primary care colleagues around helping them understand what resources are available to help women improve their functional capacity, but also to provide them with resources around one of their biggest resources. And one of the things I think they can do to help women the most is, if a woman has had an event, is to really talk to them about rehab, whatever type it is, and to help them understand that it's probably one of the most important things that they can do for themselves. And in Kelly's case, it was great that she had a doctor who would write some, say that she had to be off work. I think primary care has a big role in that, and we need to help them understand that and really push them to help us help the patient.
Jodi, do you have any other comments?
Yeah, I think, within my institute, of course, there's a real strength in terms of, being a women's focus with the Women's Heart Health Center. But I think that one of the remaining gaps is just understanding that the comorbidity burden is different for women than men. And so that's one of the remaining things here that I find with my program being related to both brain and heart, that as some of the data was presented, there's higher burden of depression, there's a higher burden of anxiety in women, and this impacts how they're going to do. And so I think that that's one of the steps moving forward, is just understanding the comorbidity that comes, the sex-specific comorbidity that comes with it, and addressing that in addition to the rehab.
And Kelly, did you feel that your information was communicated well between acute and rehab when you had your cardiac rehab, or are there opportunities that you saw that other people can benefit from?
I definitely think that there was some miscommunication at times. When they told me that at the hospital that there was an opportunity to do the cardiac rehab because I was in Hamilton having surgery and the rehabilitation would be in Niagara Falls, there was a problem with that. Like, initially they had sent me to Hamilton, and then we had to call and we had to figure all that out. So eventually it was figured out. It wasn't terrible, but it was one of those things that some women might have been like, oh, well, I'm not going to do it. Instead, like, when you do have so much to do, I did find it very important to attend. I've always been the kind of person who works out, goes to the gym, swims, yoga. So I am more of an athletic person, where someone who's not maybe would have just shied away from it.
Great, thank you. And then another question, which I'll let everyone take turns and maybe start with Jennifer this time. Do we have enough evidence to start creating specific tailored programs for women in cardiac rehab and stroke rehab? So maybe Jennifer first and then Anita.
Well, I think what we know in cardiac rehab is that cardiac rehab works for women if we can get them there. We do very specific things in our program because we are women-only program. We realize that women have a higher comorbidity of musculoskeletal and depression. So we have reclining bikes and things that are easier on the bones and joints than some other programs have. And we have a big emphasis on support. So how do we provide care for anxiety, care for depression, but also the social support that women are needing? So I think in cardiac rehab, the evidence is there. It's just figuring out how to deliver that.
Anita?
Yeah, for stroke rehab, I mean, I think again, there's two different things to look at. There's the delivery of the programs and how we do it, and then there's the content of the programs. And I think that there is some, differences that we can look at in terms of how we deliver our programs to women based on, where they may be in their lifespan, what being able to factor in the specific roles and responsibility that the women may have, and also with our caregivers as well. So I think in terms of the structures of our program, yes. In terms of sort of the differences in the neurotherapeutic techniques that we use, I think that we still have a lot to learn and a lot to look at to be able to really tailor the content of our therapies.
Great, thank you. And I think we have time for one more question, so I'm going to let Kelly have the last word. Kelly, it's a double-loaded question. One is that you talked about how important your husband was in helping you advocate. And so from that, what advice do you give to other women, especially women who may not have a partner with them? And then the second part of the question is, did you have conversations with your children about what was happening to you, and how did you approach that? So maybe let's take the first one about having a spouse or partner involved, and if they're not available, what is your advice to other women?
Unfortunately, I think my advice usually, because I do give it to others, is to bring anybody else with them, to vouch for them, because I'm not sure why I needed someone to vouch for me. I'm not sure why my word wasn't good enough, but it doesn't seem to be. Even still, after all this happened, my word isn't enough. So if you don't have a husband or a brother or a grandfather or someone, a friend, then I'll go. I said I would go with them, because I think everybody needs somebody for whatever reason. I hope that changes one day, that our doctors will take what we have to say at face value. But until it does, you have to bring someone with you to help.
Mm-hmm. And the second part about, you had 2 young children, and I know that's a situation for a lot of women. Do you have any thoughts or advice regarding talking to your children about what's happening?
Yeah, I am very honest with my kids about everything that's happened, because if I do pass away at some point, given that I still have some difficulties, I don't want it to be something I lied about. I don't want to say, oh, mom's going to be fine, and then I'm not here, and they're left with that. But I also don't say that much to them. I've told them that mom had to have her heart fixed, that the doctor fixed it, and when I was going to cardiac rehab, I would tell them mom's going to go do some exercises so that mom's body keeps working, as long as we can keep it here with you guys. And they know that the most important thing is that I'm here for them. I've always said that to them. I'm just glad I'm still here every day with them, because with an aortic dissection, it seems to be that I'm very, very lucky to be here with them, and I want to make every day count now.
Thank you. Those are very moving words. On behalf of Heart and Stroke, I'd like to thank everybody for our presenters for giving a fabulous presentation. There's a lot of comments that have come in. Kelly, there's an outpouring of support for you. Other people will come to your appointments with you, since you're coming with them. There's been a flood of comments about support for you. And to all of our speakers, thank you so much for your expertise and your commitment and your time today. We will address any further questions. The recordings will be posted after the holiday. We really encourage you to complete the evaluation because that helps us to identify topics for future webinars and to identify areas where we can improve. And if upon completion of the evaluation, you can get a certificate if you need it. Thank you all. We, on behalf of Heart and Stroke, wish everybody a happy, healthy, and safe holiday season in however you choose to celebrate it. And we look forward to you joining us for future webinars in the new year. So thank you all very much.
Thank you.
Thank you.